So you asked me to talk about potential future therapeutic strategies in the treatment of erectile dysfunction. First of all, my disclosures. I am a member of the advisory board of Boston Scientific Company, and I'm a consultant for Coloplast and Rigicon. Let us briefly go through the epidemiology. You're all aware of the Massachusetts male aging study, where there is a prevalence of erectile dysfunction of over 50% in men aged more than 40 years. A Californian study, the Olmsted County study, had more or less the same prevalence. The Kempen study is a Dutch study from the Netherlands, and the Cologne is a German study. They all have the same, more or less the same numbers. And the message of this slide is that erectile dysfunction is very, very frequent. Erectile dysfunction, we abbreviate this with ED, as you know, but ED is also the abbreviation of endothelial dysfunction. So we talk about a dysfunction of the endothelium, the inner layer of the vascular structures in our body. And for this reason, it's not surprising that erectile dysfunction is prevalent in males with stable chronic coronary artery disease, and that erectile dysfunction is very important, an early marker of possible future cardiovascular disease. This results in papers that are also published in cardiology journals, such as a very important journal, Circulation, and even cardiologists try or begin to understand that erectile dysfunction might be an early sign of cardiovascular disease. If we want to get into possible future therapeutic strategies, we need to know a little bit about what is the physiology of the erection. So first of all, you need a stimulus, and this will cause, by neurological action, release of NO, and this will cause a raise of cyclic GMP in the smooth muscle cell, which will generate an erection by vasodilatation. What do we have for therapy right now? Well, we have PDE5 inhibitors. By inhibiting PDE5 action, you will get intracellular an accumulation of cyclic GMP. This will cause a decrease of calcium, and by this decrease of calcium, you get a relaxation of the smooth muscle cell because there will be a disconnection of the actin-myosin complexes. Papaverin inhibits PDE2, 3, and 4, and will for this reason not accumulate GMP but cyclic AMP. This, however, will also result in a decrease of calcium and will also cause a relaxation of the smooth muscle cell. PGE1, which we also use for intracavernous therapy, will stimulate, so it will not inhibit, but it will stimulate adenyl cyclase, which will again cause an accumulation of cyclic AMP, decrease of calcium, and relaxation of smooth muscle cell. And if we would administer NO directly in the body, which is of course impossible because you will have so many side effects that this is not a therapy we can use. But if you administer NO, you will get a stimulation of guanyl cyclase, accumulation of cyclic GMP, decrease of calcium, and relaxation of the smooth muscle cell. The available drugs, anyway, here in Europe, and I think in most of the countries, the first in 1998 was sildenafil, Viagra. Then we had tadalafil, Cialis, vardenafil, Levitra, and avanafil, Spedra. That are the molecules that we most frequently use. And there is a difference between the molecules in the plasma levels that are needed to achieve a PDE5 inhibition. And there is also a difference in the metabolism and metabolization of the PDE5 inhibitors, where you will have a difference in inhibitor enzyme off rate. Very important in this treatment is that you instruct the patient, because this medication will only work if there is NO available, and this NO is released by neurological action, and NO will be released when a patient is stimulated to have intercourse. If we talk about intracavernous therapy, we use most of the time prostaglandin. Phentolamine is for years now no longer available. We also have urologists that use papaverine, which is cheaper, but has some more side effects and risks. Very important here also is that you instruct the patient how to use the therapy. It happens very often with the medication, with the pills, and also with the injections, that they just say to the patient, okay, take this pill and you will see what happened. Well, you have to instruct your patient and tell him that he needs to take it 1, in advance, 2, without any meal, and 3, there is sexual stimulation necessary. The same goes for these injections. Don't just prescribe an injection to the patient. You should explain how this injection is administered. And of course, the main risk of this intracavernous therapy is priapism. I have to tell you that in my practice, which is now for 29 years, over 29 years, in my own patient population, I never encountered one priapism, and I believe this is related to a very good explanation of the therapy. We have some other therapies available. Trazolan was something we used, which is a psychological drug medication. We used this before sildenafil was available. Yohimbine, which is an alpha-2 blocker, was more or less placebo. Vacuum device is not popular in our country. And then we have also intraurethral therapy available, which is alprostadil, which is Muse or Vitaros, as it is commercially available in Belgium. I work for quite some time with this intraurethral therapy. I have to admit that this is only effective in a few patients, but it might be easier to propose this treatment if you compare to real injections with needles. This is a very important slide that you probably all know. In this slide is explained how a smooth muscle cell relaxes. And this can be a slide that is also true for coronary artery or the vascular system as a whole. You see, you need an interaction between the endothelial cell and the smooth muscle cell. And in between, you have a nervous stimulation, which releases nitric oxide, which is metabolized by using L-arginine and oxygen. So this is the important slide where you see on the lower side cyclic GMP, on the upper side cyclic AMP, and where you can see where papaverine, prostaglandin, and PDE5 inhibitors interact. Now the real topic of this talk, the future. As Winston Churchill once said, it is always wise to look ahead, but it's difficult to look further than you can see. So it's not that easy to look far ahead. We need new therapeutics in patients that are difficult to treat. And because if we have patients that are not treated or helped with the conservative treatment, the options now we have are rather invasive, which is intracavernous injections or surgery, inflatable or malleable penile prosthesis. So for this difficult to treat group, we should try to find new treatments. And why are they difficult to treat? Well, I explained this already a bit, because if you have patients after radical pelvic surgery, such as radical prostatectomy, or patients with polyneuropathy because of diabetes, they have damage of the end organ, which is the smooth muscle cell and the endothelial cell. They have apoptosis, which results in fibrosis, and for this reason, they do not really respond to conservative treatment. On the other hand, you can have a lack of NO release, which also will give a difficult situation to treat, even if the end organ is okay. So if you have a patient with, let's say, a perfect vascular system, but the complete damage of the neuronal system, for example, after a non-nerve sparing radical prostatectomy, there will be no NO available. And as I explained, they will not respond to PD5 or PG1. I would like to present now a little bit of the research that we did in my own lab at our university in Hasselt. And what you see here is when we did a penile implant, we explanted or we took some tissue of the corporal body, which was sent to the lab. This is the corporotomy. You will see those slides again in my second talk. And what you see here, I don't know whether you see the arrow, this is a lump of tissue out of the cavernous body. This is collected in a tube. This goes into a Krebs solution, so this should be a buffer because the tissue needs to stay alive. And this is when it arrives in the lab, you see that you have this spongeous tissue from the corpus cavernosum. These are the organ baths, and we had 6 organ baths that were in a setup parallel, so not in series, but parallel. And in this organ bath, you can see that there is some of this cavernous tissue in the organ bath, which is gas bubbled, which is at 37 degrees Celsius, and which is a Krebs solution, which is of course necessary to mimic the real life situation in the body. So if we had this small piece of tissue, we cut this in 6 smaller pieces for each organ bath. This is fixed to a hook on one side, and on the other side we have a hook that will cause some traction, that will put some traction on the tissue. As you can see, we have 37 degrees. This is the Krebs buffer, and this is gas bubbled with oxygen and carbon dioxide. This is the setup in the lab, and there you see the let's say the monitor to administer the pressure. These are the graphics that we got, and every experiment that we did, as you can see on this slide, you need to standardize, of course, your setup. And what we did is, so we have this tissue where there is a little bit of standardized traction, and then we administered phenylephrine, which will cause contraction. You see the tension, which is measured in grams, will raise. Then we do a washout of the phenylephrine. Then we get relaxation again by pulling with the same stretch on the tissue. We do a second contraction with phenylephrine, a second washout. Then we do a third contraction with phenylephrine. And then we do not do a washout, but we wait until we have a steady state. Washout, washout, and here we have a contraction, and we wait for a steady state. And then at a certain time, and I presume it was here because you first need to let the tissue adapt and relax, then at a certain standardized moment, we administer some kind of medication, and you see here that we have relaxation. Of course, it's difficult to set up those treatments or those experiments, because you need to make a differentiation between the tissue that is getting fatigue and the tissue that is reacting to the drug. And to know which drugs that we would try out, when we before we started with these experiments, we did mRNA expression profiles. So we looked in patients which mRNA expressions were up or down regulated. And as you can see, enos, guanyl cyclase, alpha-1, beta-1, PD5 Rho kinase, ROC1, ROC2, and collagenase, you see the results of the RNA expression profile. So these might be interesting molecules to test. And the first we tested was guanyl cyclase. So what is guanyl cyclase doing? You see this here. Guanyl soluble guanyl cyclase will, after NO stimulation, cause a metabolism from GTP to cyclic GMP, which is necessary to have relaxation by calcium levels that will drop in the smooth muscle cell. This is to remind you on the slide we have seen before with the calcium levels that lower because they are taken into the endoplasmatic reticulum. This was a publication we did with one of those compounds, and the name of the compound is BAY from Bayer, and then 60 with a number, which is where we tested the new compounds of guanyl cyclase from Bayer. And you see we do this, of course, in patients that had a penile implant surgery scheduled, and those are by definition PDE5 inhibitor non-responders. These were the characteristics of the patients, and as you can see here, you see that if we administered SGC alpha 1, you see the control group versus the erectile dysfunction group. So you see that there is a difference. And here you see we administered vardenafil, we administered guanyl cyclase, and we administered the combination. And you can see here that you have with the combination a better relaxation compared to only PDE5 vardenafil. And why vardenafil? Because we did these experiments in collaboration with Bayer, and this is of course the Bayer drug. Rho kinase is also an interesting molecule that has been looked after in experiments, and for this reason we used another molecule from Bayer, which was Y27 etc., the number, and we did it again in patients with erectile dysfunction and PDE5 inhibitor failure. So this was, for example, Peter Sandner, who is involved in these studies, is one of the main investigators from Bayer, who was one of the people that was responsible for the vardenafil research. What is Rho kinase doing? Well, you see, it also causes vasodilatation because it has an interaction on the myosin light chain phosphatase, which is necessary to relax smooth muscle cells. You see where Rho kinase acts. So if you don't get this effect of the myosin light chain phosphatase, so if those myosin light chains are not with a phosphor added molecule, you will have no relaxation and no vasodilatation. This is a little bit more complicated slide where you see how ROC or Rho kinase inhibition works. So Rho kinase gives contraction of the smooth muscle cell. So here you need to inhibit, and there are two kinds, as you have seen in the mRNA slide. You have ROC1, which is mainly active in inflammation, and you have ROC2 that is active in vascular tissue. So for this reason, you see in our experiments little or no difference in the ROC1, but a big difference in the ROC2 mRNA expression, as we have seen in the first slides. This is, we did also immunohistochemical analysis to see where this activity is located. And here you see that we looked after two different, we have azayindol, and then we have the new molecule from Bayer, Y27, etc. You see with this experiment, when we did vardenafil, this is the stabilization of the tissue after phenylephrine contraction. Once you have stabilization, we administered vardenafil, you see relaxation, and then we added a Rho kinase blocker, which gave more relaxation. And as I explained to you, relaxation is related to erection. This is a slide where you see the same, but in another graphic. Stem cell therapy. Stem cells, you can find stem cells from the bone marrow, or you can take them adipose-derived stem cells or bone marrow derived stem cells. They play a very important role in wound healing. Many publications have been done also on their effect in Peyronie's disease. But let's say altogether, when you go to meetings, I was recently in last week, more precise, I was in Miami at ISSM and SMSNA, and you see that the number of presentations and talks on stem cells are lowering, and you see that the effect that we were expecting from this treatment is not really that promising as we wanted. ESWT, so extracorporeal shockwave therapy, low intensity shockwave therapy. I do this treatment for about 25 years now. And I have to say, I did this, and I do this only in one indication. And this indication is the acute phase of Peyronie's disease. I was never convinced that this therapy would improve erectile function. However, many papers published by Vardi, but also other authors, tried to prove that this shockwave therapy had also an effect on erectile function. Again, when I refer to the presentations in Miami last week, we see that the effect on erectile function is not clear. And if you look to the EAU, the AUA guidelines, this is not withheld with important level of evidence. The only effect I think that we know for this at this time is that it might have an improvement on pain reduction in acute phase of Peyronie's disease. Many theories have been published, and one of them is that it might be a stimulation of neoangiogenesis. You know that these acoustic waves result in a positive pressure. It creates some mechanical damage. You get bubbles inside the blood vessels. This will cause a shear stress on the endothelium, and some growth factors and progenitor cells might be triggered. There were publications that you could treat a non-responder on PDE5 inhibitors to become a responder, but in conclusion, the literature so far is not conclusive. There are different protocols that are not real good randomized controlled trials. There are many different devices used, many different energy levels, many differences in number of shock waves, etc. So, conclusion, we do not know whether this has an effect. EMDA, electromotive drug administration. I used this also 25 years ago. Iontophoresis is this, and this was a very promising treatment. So this is a transdermal electromotive drug administration where you can use any drug. I use this treatment again in the acute phase of Peyronie's disease with verapamil, which is a calcium entry blocker, and dexamethasone, which is a corticoid. And this had, for sure, in studies proven an effect on penile curvature and plaque size. However, again, the same problem with shockwave therapy. There are not really standardized protocols, different machines, different molecules, different protocols, etc. So I think we cannot really be very affirmative on this treatment. But in the guidelines, EAU and AUA, you see again that this might have an effect on the acute phase of Peyronie's disease. Clinically, this means it might, and I do not say it will, but it might diminish pain earlier. This is how it works. So you need a cup that is placed on the penis, and in this case on the plaque of the Peyronie's disease, and this is how it looked in real life. This is the cup on the penis, and then you have an electrode because it's an electromotive, so you need an electric current that will stimulate migration of the molecules that you have in this cup. It will cause mobilization of the molecules into the sick organ, in this case in the penis. This is something I think that might be promising, but difficult in real life. And this is the non-genomic effects of testosterone. Yesterday, I had a lecture for the students at my university, and this was also on the non-genomic effects of testosterone. And when I talk to many people, whether it will be students or general practitioners or even urologists, not many people are aware that testosterone has also non-genomic effects. These are the genomic effects. In bodybuilding, they use anabolics, and then you will have a genomic effect, which is, as we all know, for example, generation of more muscle and more strength. This guy, Lance Armstrong, he won, but he lost his maillot jaune, but he won, I think, 7 times the Tour de France. And this was his friend, let's say, Floyd Landis, and he won twice the Tour de France. And in one of those, one of the days he won the episode, it was very strange because they found very high levels in his blood of testosterone. And these made me think that there might be something else playing, because this is not the effect of the bodybuilder that you see here. And what is the effect of testosterone? Well, these are the genomic effects, for example. Testosterone will cause adipocyte accumulation, in this case in the rabbit, penile corpus cavernosum. So you will have more fat cells in the corpus cavernosum. And this is something that you see, for example, in castration of rats, where you see that you have more fat cells. Here you see clearly the white zones are the fat cells, and this is what you see after testosterone deprivation. And if you re-administer the testosterone, you will see that this will become normal again. This is briefly how testosterone works. So it is formed from cholesterol on, and you finally have dehydroepiandrostenedione, so DHEA. Then you have androstenedione and then testosterone, and the active metabolite is dehydrotestosterone. So this is how it goes in the cell. Testosterone is, as you all know, a very important molecule that is produced in the Leydig cells, or the cells that are the interstitial cells that are between the seminiferous tubules. This is mainly bound to plasma proteins, and most of the proteins are SHBG. This is regulated by LH, as you know, so there's a circadian rhythm with a peak level in the morning. And the genomic effects, you know, they are mentioned here. And the active metabolite is DHT, because this has a more stable binding with the androgen receptor in the target cells. So genomic effects: hematocrit, spermatogenesis, bone density, cholesterol, muscle strength, libido, general well-being, general mood, etc. This is what you know. But what about the non-genomic effects? They were for the first time already described by Celli in 1950. And the non-genomic effects of testosterone are blood vessel dilation. And of course, if you get blood vessel dilation, this might also be important in blood vessel dilation in the corporal bodies to cause erectile activity. It also causes tracheal relaxation. And this testosterone, one of the problems is that it is lipophilic, because it comes out of cholesterol. So it has to be tested in a setting where you have the testosterone in membrane preparations, where you have fat components. Important of a non-genomic effect is that there is no mRNA transcription. So this means it does not work through an androgen receptor, and for this reason it has a rapid, immediate effect, because there is no transcription of mRNA and protein production necessary. The mode of action, you have many articles published on this. Altogether, we do not know, but we do know that the receptors for the non-genomic effect are, because of the lipophilic nature, often located on the plasma membrane. You have non-genomic effects also on the Sertoli cells. You have effects on the immune response in the body and on the calcium homeostasis. Now, the vasodilatation effect, which is, of course, the effect that interests us. And I want to get back to this Tour de France, which was in 2006 with Floyd Landis. He was first in the ranking, and then he lost 8 minutes in the Alps. And 1 day later, he had a monstrous escape, and he had a revival, which was very strange. And then they found high levels of testosterone, and he was disqualified. And when I read this in the newspaper, I'm not a big fan of those cycling events, but of course, in Belgium, France is next to my country. You cannot live in the world and not being aware of this Tour de France. And when I read in the newspapers, my first idea was this is not true, because testosterone is working only after weeks and months, because it has a genomic effect. But nevertheless, he was disqualified. And I was thinking, why is this possible that this effect was immediate? And we do know that it has effects, for example, on the coronary arteries. And as we explained earlier, the coronary arteries are the same as the arteria cavernosa, only with a bigger diameter. So there were done experiments in dogs where they measured with Doppler, and they saw when they administered testosterone that you had a vasodilatation of the coronary arteries. They did the same in coronary arteries and in the aorta of rabbits. I will go a little bit quicker because for the sake of time. This is very interesting. In man, so in humans, we have seen that if you have myocardial ischemia, which is an infarction, you will see that the damage to the myocardium will be less if you administer also testosterone. We have also studied, not in my lab, but in animals, effect on mesenteric arteries. These were rat experiments. You have also effects on the pulmonary circulation. So you can imagine if you administer this in a cyclist like Floyd Landis, if you have better oxygenation of your blood and you have widening of the coronary arteries and you have more blood and more oxygen in your muscles, well, this gives, of course, the effect that your condition and your power will be bigger. Now, what we really want to look into is effects on the corpus cavernosum. And this is a very, very, very interesting paper already published in 2000. What has been done in 54 humans, healthy, potent men, testosterone levels were measured during different phases of erection, and there were blood samples taken at the cubital vein and the corpus cavernosum at the same time. And they did it flaccid, tumescent, rigid, and detumescence, and the induction of erection was done either with audiovisual or tactile stimuli. And if you see that in the flaccid state, you had certain levels, and during tumescence and erection, you see that the testosterone levels raise. And after erection, when you have the tumescence, the testosterone levels dropped. And these testosterone effects are mainly seen in the corporal body and are less pronounced in the cubital vein, so in the systemic circulation. So if you know this, that you have an increase in concentration of testosterone in the corpus cavernosum, this must be because there is an effect locally in the corporal bodies, which is namely erection. So what is the function of this testosterone increase in the corporal bodies? And a very important question, where does the testosterone originate? Because it is produced in the testicles, not in the corporal bodies. So it has to be stocked somewhere and released at the time of erection. So we did the same experiments in also in our lab. One publication that there's only one that I know that has been done in male patients, but these were patients that were for gender reassignment surgery scheduled, or for a penile carcinoma, penile amputation. And this is, of course, a study limitation because, for example, the gender reassignment patients have been treated hormonally, and this has for sure an effect on the tissue. So these are the experiments that they have done. Now I want to give you some of the results that we have already published now. And you know this picture on the upper right corner of the slide. This is the tissue that we took away doing a penile implant. We compare testosterone versus dihydrotestosterone versus placebo, DMSO. Grapes, 37 degrees, 6 baths, the strips. You know, these are PDE5 and PG1 non-responders. We did not include Peyronie's patients because they are a sub-classification, and we did with the same setup. And there you see the difference between testosterone and dihydrotestosterone on the graphics. And these are the dose response curves. And you can see here that testosterone has a very good effect on relaxation because you get a drop in contraction rates. So this is again with a 5-minute interval. You see the difference between testosterone, dihydrotestosterone, and DMSO. These were the statistical relevant values. So you see this is statistically relevant, and this research, of course, was only possible with collaboration of many people involved, also from the US. And this is my final slide of this first presentation. You proposed the following title: Light at the End of the Tunnel for Unresponsive Erectile Dysfunction. And penile prosthesis has been my field of interest for nearly 30 years now. This is a real mushroom that we have, a fungus that we have in our country. I don't know whether you know this in Vietnam. The name in Latin is Phallus impudicus, and impudicus means without shame. And it really looks like a phallus because you see 2 testicles, you see the shaft, and you see the glans. And one very specific characteristic of this fungus is that it has a terrible smell. My disclosures I mentioned already. Let us first talk about the indications. 1998 is a very important cutoff year. And if I look into my own practice, before 1998, I started in 1993. And you should know that penile implant has been available since 1973. So when I started my practice, penile prosthesis was available for about 20 years. And after 5 years, I was able to do around 15 patients a year. And after 1998, my numbers dropped to 50%. And the reason is that at 1998, sildenafil became available. And this was the first available oral drug to treat really erectile dysfunction. Because before 1998, we did not have any other treatment than vacuum device, injection, and no pills. However, if you look at the pre and post sildenafil era, you see that the number of patients grew. And I think that in this year, and we are now not post sildenafil but post COVID, I will do more than 150 penile implants a year, between 150 and 200 cases every year. And the reason is, one, that if you were treated with PDE5, many of those patients became non-responders or dropouts. Non-responder means that the drug that was successful in the beginning will, after some years, not be successful anymore. Another thing is that PD5 treatment made erectile dysfunction discussable. It was very easy for a patient to go to the doctor and say, well, I have maybe some other small problem, without naming his problem. So just saying, well, doctor, I have another small problem. What do you think of the blue pill? So without naming his penis, his impotence, his erectile dysfunction, without naming Viagra, he just mentioned the blue pill and everybody knew what he was talking about. So patients had an easier way to start discuss this matter. And this is something, an effect that you even see nowadays. Patients still talk about the little blue pill. I do not really like penile prosthesis as terminology because this sounds, as far as I'm concerned, very artificial, because it looks a little bit like you might add something externally to the body, artificial plastic. So the best terminology, I think, is erection prosthesis, or let's call it erectile implant, because this is what it really is. However, we speak in most of the cases of IPP, inflatable penile prosthesis, and the only thing I want to mention is that penile prosthesis, if you use this terminology, many patients have a wrong idea about what you're talking about. Historically, in 1936, which is nearly 100 years ago, Bogoras, who was a urologist or a surgeon in South America, he implanted rib cartilage. So this is the first surgical attempt to implant something in the penis, in this case subcutaneously, to achieve rigidity, to make intercourse and penetration possible. Of course, this was not a success. This is only for the history that I always mention, this first attempt. It is striking to see that Scardino already in 1950 was testing the first synthetic implants. And in 1960, the first intracavernous implants have been implanted. And as you all know, 1973, which means next year, 50 years available, half of a century, Scott, Bradley, and Tim had the first inflatable penile implant with 2 pumps. 1974, you had AMS, which was the first company that American Medical Systems, nowadays Boston Scientific, that made the implants available with the AMS 700. And 10 years later, you had Mentor, nowadays Coloplast, that was and became the second big player in this market with their implants. This is a picture of Bogoras on the left side, and this was the result he achieved with the rib cartilage. I would like to mention the EAU guidelines now, and they are more or less the same as the AUA guidelines, and something changed. And what did change is that a penile implant is indicated in patients who fail pharmacotherapy or who want a permanent solution. And 2 years ago, it has been changed also that there's also in the guidelines patient's preference. So what the patient wants can be an indication for a penile implant. This means in practical, in real life, so if you have a patient, years ago, you had to say to the patient, no, first you have to do pills, and then we do the second level with vacuum or injection, and then maybe we can talk about a penile implant. Today, if you have a patient and this patient tells you that he does not want to take a pill 1 hour before intercourse, he does not want to use a vacuum device, which I can easily understand. Many patients say, I do not want to inject myself with a needle in the penis, so I want a permanent solution. Well, you can propose to this patient at once the option of a penile implant. I do not do this in my practice, but this is today possible that you do it like this. I think you should at least try with pills before the patient is scheduled for a penile implant. One exception, for example, might be patients who had a priapism and became, of course, impotent because they developed a completely fibrotic penis. In our country, over 95% of the patients will prefer a 3-piece inflatable penile implant because the erections are more natural. And very important is we talk about quality of life. So the main outcome of a quality of life treatment is satisfaction. And to have a good satisfaction, a high satisfaction, you need an appropriate consultation. To have this and to be successful, you need a well-trained and well-organized team. You have to collaborate with other people, and this is the same in oncological pathology. This is the same in incontinence. This is the same in pediatrics. You need to involve other people. It cannot only be you treating the patient. If we talk about penile implants, of course, the urologist is a central person in this team, but you need to collaborate sometimes with cardiologists because of the relation with cardiovascular disease. You need to collaborate sometimes with the endocrinologist if there is a testosterone issue. You might need to interact with the sexologist if there is a mental condition that can be important. And in some cases, you even can collaborate with a gynecologist. More important than the medical multidisciplinary team is the paramedical support. I do have at my own practice in my hospital nowadays 3, and in the coming months there will be 4 penile implant / prosthetic nurse practitioner. This means they are specialist nurses, dedicated nurses that focus on penile implant. But I mentioned prosthetic nurse because I also do artificial urinary sphincter implantation. And my prosthetic nurses are helping me for both the implants. Very important is also that you need to have a very experienced team in the operating room. I have 6 to 7 nurses available in the OR that assist me exclusively with this kind of surgery, which is very important to have a good outcome. And finally, you need to have nurses on the ward that do know what these patients need before and more important after the operation. These are my 3 prosthetic nurses today. You should also standardize your workup. You should standardize everything you do. This makes the results better. Everybody knows what has to be done. It makes life easier. One, most important, you need to do integration of the couple. I think you should also see the partner before you start this kind of treatment. I do this even with patients that are treated with PDE5 or injections. You always should aim at seeing the partner and involve the partner in the treatment. If you are collaborating in studies, it's interesting to have symptom scores. You do know that you have to measure testosterone in all those patients, and I do a pharmacodoppler in all patients I schedule for a penile implant. This has many reasons. One of them is that I have an ID on the vascular status of the patient. Second is that I can test the effect of an intracavernous injection with a standardized dose of 10 micrograms prostaglandin, where I can see what is the effect on the penis. And by doing this, you can show the penis and the patient and explain him, this is how intracavernous therapy is working. Sad enough, nocturnal penile tumescence measurements are not really available anymore. I have to tell you that I am working for a couple of years now on a tumescence wearable app, which will become, I hope, available commercially in the near future, because we have already for a couple of years a patent on a new system that will be much cheaper and much easier to use. You need to have clear documentation to give to the patient. You must have a model available at your practice, and I do not do this in all patients. I used to do this a long time ago, but if a patient wants to see the real model, you should be able to show him. All my patients have a pre-op counseling with the nurse practitioner. This is important because it takes at least 45 minutes to counsel a patient correct before you move on with this kind of treatment. And in our practice, for us as doctors, as urologists, we do not always have the time and maybe not always the patience to have 45 minutes or 1 hour to talk with the patient to counsel him. Guarantee, this is difference between the companies and between the different devices also, but in some cases, for example, the new company now on the market, Rigicon, as a commercial strategy, they give a lifetime guarantee. So as I say, this is not always the same in every country. In our country, a penile implant is a cheap solution. I can imagine very well that this is in Vietnam, in your country, different. Why is it cheap? Because the total cost of a penile implant in Belgium is more or less 9,000 euros or US dollars, more or less. This is covered nearly completely by our national health system. The patient has to pay of this $9,000 only 1,000. Many patients do have a commercial extra reimbursement system, so they even get paid for this 1,000 euros. So many of the patients do not have to pay because they have on top a private insurance, and for many patients it is free. They do not have to pay anything, and this is of course a very important argument in suggesting this treatment to your patients. Also important is that you should have some patients available that are willing to testify. Sometimes the patients ask you, can I have contact with a patient who has an implant and ask him some questions on his personal experience? Well, I do have several patients that are willing to do this. You should explain also to the patient that a penile implant can develop after a certain time mechanical failure, and sometimes you need to do a reoperation. In well-experienced hands, complication rates should be low, and surgically spoken, it's a small operation because it's one single incision, penoscrotal, in my patients, and the operation takes about 30 minutes average, and they have to stay in the hospital for 1 day. So for this reason, it's a small operation. However, mentally, it's a big operation. Penile size, if you look at the dissatisfaction after a penile implant, the most frequent reason for a patient telling you that he's not completely happy is the size of the penis. You should explain the patient that it is not the penile implant that will reduce the penile size. It is the erectile dysfunction that caused reduction of penile size by fibrosis. You should explain your patient that a penile implant is an irreversible procedure. It does not interfere with the ejaculation or orgasm. It only provides the patient with rigidity, making penetration and intercourse possible. It's important that you should aim at low preoperative expectations. So do not promise heaven. You should under-promise and over-deliver. Once again, I want to stress on standardized workup, also perioperative. You should have a fast track in this multimodal intervention. Preoperative, the nurses should be instructed how to prepare the patient for the surgery. In the OR, you need to have a well-trained surgical team, specifically for the assembly of the device. Post-op, it's important that the nurses on the ward know when to remove the catheter, what about the bandage, the mummy wrap, when to deflate. Of course, I work with residents, and they are most of the times responsible for this immediate postoperative care. The patient is going home after 24 hours, and you should instruct him before he is dismissed. I think also very important, which is not in every country and in every situation possible, you should arrange a quick control after the operation to your outpatient clinic. You should also involve nurse practitioners in the postoperative period. What are the types of implants available? Well, Boston Scientific is American Medical Systems, as I told you previously. Mentor became Coloplast. They are the big players on the market. You have for a couple of years also in Europe, Zephyr, which is a Swiss company. And now very recently we see that Rigicon, which is a Turkish-American company, is on the market with a new implant. They also have a sphincter. I explained already that most of the patients will choose an inflatable implant because this has more natural erections. You have a flaccid and erect penis. On the other side, a malleable implant will always be hard. A three-piece inflatable implant consists of 2 cylinders. You can compare this a little bit to an inner tire inside the external tire of a bicycle, for example. You need a pump to pump up the cylinders, and of course you need fluid in a reservoir, so you can move the fluid from the reservoir to the cylinders and back. In a 2-piece penile implant, which also the Ambicor, for example, you only have cylinders and the pump, and the reservoir is located at the base of the cylinders at the proximal end, and by definition you have less fluid that you can shift from one side to the other. These are some characteristics of the malleable prosthesis. You have a constant rigidity because it's always hard. The procedure surgically is much more simple because you do not need to insert also a reservoir, which can be a difficult and challenging part in the surgery. And of course, you will see technical problems very rare. If you, for example, puncture this implant with a needle, it will not be damaged because there is no fluid inside. When I do a malleable implant, it sometimes happened, I do on purpose a stitch through the implant to fix it to the corporal body, to the tunica albuginea. So the disadvantages might be aesthetic because you always have an erect penis, and there is a higher risk of erosion, especially in the spinal cord patients, because you get a constant distal pressure, which might cause, after a certain time, erosion. So malleable implants are recommended for patients with a compromised dexterity, but it might be appropriate in other clinical situations, which is in the guidelines. In my country, it's relatively unpopular. As I told you, I think that less than 1% of the implants I do are malleable. However, if you counsel the patient well, you will have a high percentage of patients that will be satisfied. They cannot, of course, compare between malleable and inflatable. A funny thing is, because I am working in a different country, so the malleable implant is cheaper. So in countries where you do not have reimbursement, this can be an important argument because it's cheaper for the patient. In Belgium, a malleable implant is more expensive, and the reason is that this is not reimbursed in our national health care system. So the patient has to pay for the whole implant, which is more than $2,000. The total cost, of course, will be lower because the implant with the surgery will be cheaper compared to the inflatable, but not for the patient in Belgium. The 2 main companies, and now also Rigicon, do have a malleable device available. And as you can see, it's always rigid, but you can bend this implant in a more acceptable situation for your social life. What might be the indications for a malleable penile prosthesis? As we have seen, patients with compromised manual dexterity. However, even those patients are in many times in the possibility to work with the pump. Sometimes you can involve the partner to use the device if you have an inflatable. In post-priapism, I have to tell you, and we published these data together also with Faisal Yaffi in California. Post-priapism, many surgeons implant first a malleable. I think that the problem in a priapism is the fibrosis of the corporal bodies. So if it's difficult to get a malleable cylinder inside, it's also difficult to get an inflatable. The problem is not the pump, and the problem is not the reservoir. If you do a malleable, especially in my country, many of the patients will have to be reoperated to change the malleable into an inflatable. So I prefer to do in priapism patients directly an inflatable implant. It can sometimes be an indication in spinal cord injury patients because they can administer a condom catheter more easily. For example, in Holland, the Netherlands, where the guidelines are very, very, very strict before they have a reimbursement, this is one of the indications that you can implant a malleable implant in the Netherlands when you have a spinal cord injury patients that want to have a condom catheter. You can do this in salvage procedures. Also, here we have a publication with Faisal Yaffi. I do salvage also with inflatable. You should, or you can do this in severe Peyronie's disease. And I think the most important indications might be non-medical, but financial, insurance, and geographical issues. So the pros and cons of inflatable penile prosthesis: mechanical failure is more frequent, of course, with inflatable. You can have mechanical problems with the pump. You can have ruptures of the cylinders. So if you look into the 5 and 10-year survival of an inflatable implant, this is not 100%. On the contrary, the malleable implant, the 10-year survival is nearly 100%. What are the complications in inflatable but also malleable implant? You can have infection, you can have erosion, the loss of penile length. Pain is also a very important thing you should counsel the patient. It can be really painful after the operation. And if you don't tell the patient that there might be considerable pain postoperatively, they might be a little bit unsatisfied and unhappy about this. Once again, under promise, over deliver, which means you should say they might have a lot of pain. If they do not have pain after the operation, they will be happy and they will say, okay, you told me and it was not that bad. If you say you will have no pain at all, they will be unhappy because they will tell you, you said to me it wouldn't be painful and I had a lot of pain. Floppy glance, this is in many cases because you did not locate the cylinders in the right position. There was also a one-piece inflatable prosthesis with the pump in the glans and with the reservoir at the base. And by bending this implant, you activated the deflating process. There is no expansion, so there was a low success. The two-piece inflatable implant, we discussed already the Ambicor with pump and cylinders. And as you can see on the lower right angle, you see that the reservoir is located at the base of the cylinders. So the most popular inflatable devices are the three-piece inflatable devices with a pump, the reservoir, which is the sphere or the clover leaf, for example, and then you have the cylinders. The cylinders are located in the two corporal bodies. The reservoir is in the abdomen and the pump is in the scrotum. Surgical approach, there are, let's say, two approaches that are very popular: penoscrotal and infrapubic. You have nowadays people that also do subcoronal. For example, Sean Park in Korea, which is not that far from Vietnam. He is doing many cases of subcoronal penile implant surgery. And historically, you could also do this surgery by perineal approach. Penoscrotal approach, which is the most popular approach now in US and Europe, gives an excellent exposition of the corporal bodies. You have, especially when you do a longitudinal incision, a full access to the corporal bodies, also at the base, at the caudal site. There is no risk of damaging the neurovascular bundles. You have a direct view on the pump placement in the scrotum. However, the challenging part is the reservoir that you have to insert blindly. For this reason, there are I was looking at the chat, but this is not a question for me. There are surgeons that do a second counter incision to insert the reservoir. I think that if you do so, you lose one of the advantages of this penoscrotal approach. And of course, 2 incisions is a higher risk for infection. The infrapubic approach, which was the historical approach, you have in these cases a direct view on reservoir placement. Pump insertion is blind, but is not as dangerous as reservoir insertion. Can be challenging in obese patients. And of course, you can damage in these patients the neurovascular structures. So summarized, penoscrotal, good exposure in obese patients, good corporal exposure. You can combine this with an artificial urinary sphincter, but the reservoir placement can be blind. Infrapubic is the other way around. Subcoronal, this means that you do an incision under the glans. You have to deglove the penis. It will give less pain. You will have, of course, a very good exposure on the shaft of the penis to correct in Peyronie's patients the curvature, but you can imagine that by this access, reservoir insertion and placement can be really difficult. So these are the 3 techniques. On top you see infrapubic, then you see the penoscrotal, and finally on the lower right angle you see the subcoronal with the deglovement of the patient, of the shaft. So you should do the technique that you like most, because if you're used to do a certain technique, you will have a quicker operation and you will have a lower infection risk. And this is the biggest fear we have in prosthetic surgery in general, and of course also in penile implant. And to get quick surgery, you need, again, this good experienced team. For example, my nurses that assist me, they prepare the device, and they do know without any communication during the surgery what they have to do. Preoperative measures are important to prevent infection, showering before the operation, shaving just before the surgery. You should disinfect the surgical area rigorous before you operate. And I think it's better to err on the safe side. You should give antibiotics at induction time. And I have to correct this slide because for 1 year now, we also give the patient fluconazole, because there is a publication from Martin Gross from New York, where they show that in more than 10% of infected penile implants, you have fungus or mycosis that is playing a role. And for this reason, all my patients get also fluconazole at induction. Laminar airflow, low temperature. Everybody has to wear a head cap and a mask on, as little people as possible in the ward, in the OR room, and the room remains closed. So nobody gets in, nobody gets out. What about draining? Steve Wilson, he is a big fan of draining because there will be less hematoma. He says, well, to be honest, many of the things we are suggesting in presentations is single surgeon experience and personal opinions, or in the best case, it might be a multicentric retrospective collection of data. So there is no real scientific evidence-based literature available that draining or no draining makes a difference. I would like to draw your attention to the Phoenix trial that I am the principal investigator of, which is run in Europe, and this is a better version of the proper trial from the US from a couple of years ago. We will do a prospective, multicentric, high and low volume center data collection, where we will, for example, also look at the importance of draining or no draining. I do not drain. In less than 1% of the patients, I put in a drain, because I think by definition that a drain is a connection between the outside and inside world, and it might be a risk for infection. For this reason, I do an inflation of the implant until up to 90%, and I do a mummy wrap, which will give compression, and you should also close very good the corporotomies, because this is where the hematoma comes from. Doing the surgery quick is that the nurse will prepare the implant, and you can go and move on with the surgery and create space for the pump, and especially create space for the reservoir. We see that in many articles available that a penile implant has a very patient and, very important, partner satisfaction, over 90%. We are talking about erection, ejaculation, orgasm, and overall satisfaction. And nearly 90% of the patients would recommend this treatment to a friend if they had a problem with erectile dysfunction. This is a paper that we published on our own patient population. And you see it was about 50-50 coloplast and AMS. And if you look at the most frequent complaint is loss of penile length and postoperative pain. If you know that these are the most important complaints after the operation, you should stress on those complaints in your preoperative counseling. And you should talk to the patient about penile length after the operation and explain that it is not the implant that will cause loss of penile length, and you should explain that there might be considerable pain. So preoperative counseling, please look at the complaints in the list on the right lower angle. These are the factors that you should stress on. And this is these were the conclusions of our paper. You see them here. And you see that extensive preoperative counseling is mandatory to get a good postoperative satisfaction rate in patients and in partners. We have also seen that we have less floppy glands in the penoscrotal approach, because we believe that you can better dilate and better insert the cylinders. The study that we published was retrospective, and there were patients still operated infrapubic and other penoscrotal. Another important thing that we recently published with many implant surgeons is the importance of the corporotomy. I think that the corporotomy localization should be as proximal as possible. And this might sound easy, but in real life, it is not easy. If you have a proximal corporotomy, you will need less rear tip extenders. And if you have less rear tip extenders, you will have a better rigidity. You will have less tubing inside the corporal body and less friction, so less mechanical problems with leakage of the cylinders. And you will prevent having the tubing superficial, which will cause a Maserati penis. So the importance of the proximal corporotomy is published in this paper. And another final paper I think that is important is how to do a good insertion of the reservoir, because this is challenging when you do this with a penoscrotal incision. This is also a retrospective analysis of over 250 patients. And let's say that the main message of this article is normally the reservoir is inserted through the external ring of the inguinal canal. You need to insert a wound retractor to open this inguinal canal. You put a lot of shear stress on these anatomical structures, and then you pop through the transversal fascia to insert the reservoir. We see in those patients with this technique that you have, once in a while, a reservoir herniation. What I do is I make a small incision on the medial side of the funiculus. The advantage is, one, you do not damage funicular structures, which you might do by inserting through the inguinal canal. Two, you have a small opening in the external fascia that you close with one suture. So it is, by definition, impossible for the reservoir to have a herniation. Another very interesting paper published by Trost in the Journal of Sexual Medicine in 2013 is the cursed patient. As I mentioned, we are doing these surgeries not to save a patient's life, but to augment and make his life, his quality of life, better. There are cursed patients that you should be very careful with. And cursed means C, the compulsive or penocentric patient. If the patient is pathologically concentrated on his and focused on his penis, you should be careful. The unrealistic patient, if a patient expects a very big penis or that this device will save the marriage, then they have an unrealistic expectation and you will have an unhappy patient. You should explain the patient that revisions are possible. And I agree with Steve Wilson that the tincture of time is a very good medicine or a very good treatment. This means that it's not because you might have some minor surgical problems postoperatively that you really need to operate again. Time might cure. So wait long enough before you operate again. Surgeon shopping, patients that are moving from one urologist to another and then tell you that the other surgeon had really maltreated him, and he tells you, you are the best. Dangerous patient. The entitled patient, there are patients that believe they really are the most important patient you have in your practice and they have unreasonable demands. Be careful. They also have a poor compliance. And finally, the denial patient. I always say to the patient, your penis will never be the same as it has been before. You should tell this to all patients, and especially in the Peyronie's patients. The penis of the patient with a penile implant will be different than the penis they have known before they had their problem. Now, the final topic, and I have 5 more minutes, is the penile implant in patients with Peyronie's disease. So what you need to do there is correct the curvature. Intercourse should be possible. You only do this when the disease is stable, and you can do without an implant penile shortening and penile lengthening procedures, but in severe cases, we do penile implants. Penile lengthening, penile shortening is not the topic of this lecture, so I will skip the slide. But if you do an implant, you can the Wilson maneuver, which is the modeling. And the modeling means that you implant a penile implant, you inflate, and then, as you can see in the middle of the slide, by manipulation of the penis, you try to correct the curvature. So you really break the penis in the opposite direction. Dangerous maneuver because you can have urethral injury. You should also protect with clamps the tubings to the pump, because by doing this you cause high pressure in the system that might damage the pump. And of course, as you see on the middle slide, with the left hand of the surgeon, you need to protect the corporotomies, or you will tear them open by this high pressure. This is the infrapubic approach, where you can see the corporotomy. You can see the device inside. This is the penoscrotal approach, where you have a different access to the corporal bodies. This is the measurement with the furlough. This is the cylinder inside. I have to tell you that these slides are rather old, and what is changed very dramatically nowadays is, one, the corporotomy in this slide is far too big. It should be much, much, much smaller. It should be much more proximal, and the surgical field, the drapes, should be much more close to the penis. There cannot be so much skin left free, because skin is the origin of the infection. So once again, you see the corporotomy should be lower, and The drapes should be just next to the penis and the scrotum. Sexual intercourse is allowed in normal cases after 6 weeks. However, we do activation of the implant as soon as possible, and these were data that we learned from the proper study. And activation means that you try to learn the patient how to manipulate and inflate and deflate the implant after 3 to 4 weeks. You will have a better outcome if you have a high volume. You should have fast tracks. You should reassess your surgical procedure once in a while. The partner is very important. You should have written information, informed consents, because this is nowadays a very important topic. What about hematoma? We discussed this already with the watertight closure, with the inflation, the mummy wrap, scrotal support, ice, and then the question drain, no drain. I hope that we will have the answer now in the Phoenix trial. The floppy glands, most frequently because inadequate dilatation and inadequate cylinder position. Crossover, this means that you can have the cylinder that goes from the right to the left side, and both cylinders are in the same corporal body, or the other way around, and this is because of the fenestrations that you have between the corporal bodies. Another complication might be perforation, proximal, which is not that bad. However, distal perforation in the urethra or through the glands is normally the end of the procedure. Then you should abort. This is why you have crossovers. This is from Daniel Osmanov from Kiel, from the anatomy lab. You see that between the corporal bodies, you really have openings. There is really a connection between the two corporal bodies, and this is the reason that you might have a crossover. Urethral injury, very serious. You have to abort the procedure, and the insertion of the reservoir is the most challenging and dangerous part, because you can have very serious injuries, and the most feared injury, of course, is a vascular injury, where you might have even life-threatening situations, because the bleeding can be very, very heavy. Infection, the most feared complication, and we try to prevent this because prevention is the best treatment. And I go a little bit faster. This is the paper from Martin Gross that I referred to a little bit earlier. They found out in this very interesting paper that in 10%, around 10%, you have fungal like Candida. You see 11.1% is Candida albicans. So this is important to take into your regimen for antibiotic strategy. High volume centers has lower complications and lower revision rates and lower infection rates. These are some of the serious complications you might see. Erosion from the cylinder, and on the right slide you see erosion of the pump. This is due to mechanical pressure or due to infection. The complications might become more and more serious, and one that I have never seen and I hope never to see is glandular ischemia, which might lead to amputation of the glands and is luckily very, very rare. You can see this, for example, in the very dangerous sliding procedure, because you have injury to the corpus spongiosum, which is responsible for the vascularization of the glands. And this is a picture of a glands necrosis. I think this is my final slide. I like to end with words of wisdom. One of them is, in the first place, do not harm. In Latin, primum non nocere. So your treatment might not be worse than the condition or the disease of the patient. Another very important message is, you should not aim at perfect. Try to be good. Try to have a good result, because best is the enemy of good. If you have a good result, stop. If you add more and more steps to the surgery to aim at a perfect result, you might end up with a very bad result because of a complication. This is a saying by Goethe, a German poet, and in German it's in der Beschränkung den Meister zeigt sich zuerst, which means in restriction the master shows first. It's not a shame that you cannot do everything. So if you have a patient, for example, with a priapism, and you do have not that much experience in penile implant, it's not a shame to say that this is not my field of experience. I will refer you to an expert. And also very important, I think, if in erectile dysfunction, a mental problem is the most important problem of this patient, you should not treat this mental condition surgical. This is the last slide. So if there are any questions, I will be very happy to answer them. And if I look at the time watch, we are right in time.
Thank you, Professor Rosterlands. Trong phòng này của mình có những ai có câu hỏi về liên quan đến đặt thể hang nhân tạo không thì mình có thể đặt ra cho thầy. Mình sẽ có khoảng độ 10 phút để Q&A với thầy Rosterlands. Các bạn ạ.
I hope this was not
thank you, Professor Renterghem, because you give us a lot of experience about on IPP. It's very, very useful for us today, and then now we are waiting for the question from the audience.
Maybe I have a question. I have a question for the audience or for you, Quan. How many penile implants do you have in your country, and how many people are in Vietnam altogether? So in Belgium we have 11 million people and we have around 350 implants every year. So what are these numbers in Vietnam? How many people, how many implants?
I think in Vietnam's IPPs nowadays will be developed day to day because at the present we are the first experience. My big brother, Dr. Trương Hoàng Minh, after will have a lecture after you have experience about more than 30 cases, and then in one center. I think that in all our whole countries about 15 or nearly 16, 50 or 60 cases a year. In my hospital, I have just carried out the first cases the last month. Now we are looking for the results. That's why I organized this conference about the IPP today.
And how many people do you have in Vietnam? The population?
I think the erectile dysfunction patient.
No, the total population in Vietnam. Total population. How many?
More than 19 million.
Okay.
More than 19 million people, and about more than 50 million men. Yeah.
Okay.
I think.
Okay. Yeah. Okay, so that's a big difference. You are much more people and many less implants.
Yeah.
That's a big difference. Okay, are there any questions, please?
Yeah, mọi người có câu hỏi gì không? Anh Minh có hỏi gì thầy?
Chắc cái bộ phận dịch translate cho tôi cho nó tiện nhé. Dạ. Dạ, xin chào giáo sư đến từ châu Âu. Dạ. Đến từ Magic. Dạ. Thì rất là cảm ơn cái phần trình bày của giáo sư. Tôi thì đến trễ cho nên tôi nghe cũng khúc sau thôi. Thì xin có một cái câu hỏi giáo sư thì là trong kinh nghiệm của giáo sư khi mà có những cái bất thường về bơm về bơm thì có trường hợp nào mà nó thứ nhất là cái tỷ lệ bất thường của bơm là bao nhiêu % ở châu Âu? Cái thứ hai đó là giáo sư đã gặp cái trường hợp nào mà cái bơm nó tức là nó tự động nó bơm khi không có kiểm soát được không? Và nếu như mà trong trường hợp như vậy thì mình sẽ xử lý bằng cách nào, trường hợp nào thì có thể phải là phẫu thuật lại, và thời gian phẫu thuật sẽ là bao nhiêu lâu, tức là sau khi phẫu thuật. Cái thứ hai nữa là nếu trong trường hợp mà phải thay pump thì chúng ta có thể phải thay cả cái cylinder với pump, hay là chúng ta có thể chỉ thay cái pump không? Là xin hai cái câu hỏi như vậy. Xin bộ phận dịch translate cho nó.
Professor, we have a question for you. Is that
Okay.
The first one is, do you have any case that have a malfunction in the pump after the operation? Because there's a case that the pump automatically pump from the reservoir to the cylinder after, and it cannot comes down. And the second is, if there are malfunction in the pumps, then should we wait and how long until reoperation to fix the pump?
Okay.
So when we want to replace the IPP, then we replace everything or just the pump only?
Okay, these are three questions. So first, let's start with the pump problem. There are different possibilities, and the first question you should ask yourself is, and maybe you should make an ultrasound, if there is a leakage of fluid because you did something wrong or something happened, your pump will not function. So you can do an MRI, which is very expensive, but in our country it's easier, but an ultrasound, you can do it yourself. And if you see that there is no more fluid anymore, then there is not a problem with the pump, but you have a problem with leakage. That's one thing. The second, what are the possible problems if there is really a problem with the pump? You can have what we call sticky pump, which means that the pump is attached to the skin and it's not free in the scrotum. This is mainly because of low-grade infection. And this you might treat with long-term, low-dose antibiotics. There can also be pump stiction, which is a different thing. Sticky pump is when it's sticky to the scrotal wall. Pump stiction is something, excuse me, that we have seen with the Boston Scientific pump. And this means that if you try to inflate one or two times, you see the fluid is not coming back to the pump. This is a construction problem in the pump. And they really had a big problem, and they did a big research, and they found out that there was, in some cases, a problem in the manufacturing of the device. And of course, if there is something wrong with the production of the device, you need to replace the pump. I will explain later, because this was your final question. And they changed the production of the pump, and nowadays with Boston Scientific, you don't see this pump stiction frequently anymore. With Coloplast, however, we have a different problem now. That is that the pump can be extremely hard to inflate. So that even for you as a urologist, it might be very, very, very difficult to inflate the implant. This has to do with production of the device, and you should know that both devices, there is a difference. In the Boston Scientific device, the valve is inside the pump. In the Coloplast device, the lockout valve to prevent auto-inflation is in the reservoir. This is a big difference, because sometimes the problem is the valve, and if the valve is in the pump, it's the pump. If the valve is in the reservoir, it's the reservoir. When do you have to re-operate the patient? This was the third part of your question. Well, as I mentioned from Steve Wilson, tincture of time. So not too quick, because if you re-operate, the risk of an infection raises with every re-operation. If you do, for example, in a patient, the 5th re-operation on the implant, infection risk is over 80%, 80, which means most of the patients will have infection. So you should be very reluctant to reoperate. So if you have a problem with the pump, try to solve it. Sticky pump, antibiotics, long-term, low dose. Pump, stiction or hard pump, you should, what I do is I see the patient 2 weeks later, again, 2 weeks later, again, together with my nurse, and we try to get this pump and this valve working. And in many cases, you will succeed. But you need to know how to handle the pump, and this is something very difficult to explain on this distance. But what you can do, for example, is push on the inflation bulb and then push on the side of the deflation part and do this up and down, which makes the valve open, close, open, close, open, close. In the end, the problem remains the same. And I'm talking now about malfunction of the pump. You have to do a reoperation. And because this is a non-infectious complication, you only have to change the pump normally. So this is a small operation. You do, if you did penoscrotal access, you open the incision, you take out the pump, and I can tell you, because I have done this several times, it's incredible because the patient is on the table. Before you start the surgery, you check again and you see indeed there is a problem. You start the operation, you exteriorize the pump outside the scrotum, you do not remove the pump, and you try it again and it works perfect. It's funny, it's very annoying, but you check it, you check the pump that was not functioning, and it functions perfect. In one patient, I said, okay, I leave everything inside, I close again, and the patient came again with the same problem. So I never did this again. I said to the company, if there is some production problem, maybe not always, I want to change this pump because I do not trust to leave the old pump inside. If you remove the pump and you reinsert a new pump, the pump that you have removed will be sent to America, to the States, and they will check to see what was the problem. I can tell you, they never find a problem. So we do not know, I do not know why this happens, but it does. And as I understand, you have a patient now in Vietnam with this problem. And it's very annoying because you're the surgeon, you operated the patient. It's not the company that will explain everything to you and help you in this situation. You are on your own and you have to take care of this patient. But anyway, do not operate too quick. I hope this answered your question, your 3 questions. Are there any other questions?
Dạ, xin hỏi thêm ông ấy một cái, tức là khi mà thay cái pump á, thì cái xi lanh á, cylinder có cần phải thay không? Bởi vì cái cấu trúc của cái hiệu coloplast á, thì giữa cái cylinder và cái pump á, là nó liền với nhau. Thế thì khi như vậy chúng ta chỉ thay cái pump, tức là cắt ra rồi thay cái pump không, hay là phải tháo bỏ cả cái cylinder? Xin cảm ơn.
So another question is, when you change the pump, do you need to replace the cylinder as well? Because
no, I told you no. So what you do is you replace the pump, you check if the system works, and that's it. Because if you want to change the cylinders, this is a much bigger operation. If you change the reservoir, this is a much bigger operation. And the reservoir, I mentioned you, Professor Danyar Osmanov from Germany. He had one patient where he removed the reservoir. This caused damage to the vessels, and the patient died on the table because of a bleeding. So the reservoir insertion, but also the removal of a reservoir can be very, very dangerous. So to answer your question, do as little as possible. In this case, only change the pump. That's it.
Thank you, Professor. Is there any question from the audience? One question, please. Professor, have one question, please.
Yeah. Yes, I'm happy to answer. I can see you, but I don't hear you.
Hello. Hello.
Yeah, I hear you. Yes.
Yeah, I have a question about prophylactic antibiotics. Yeah, you recommend to use antifungal medication for prophylactic protocol. Can you share about your prophylactic protocols in your center? And the second question is, in which cases do you use treatment antibiotics? Yeah, thank you. Thank you, Professor.
The second part of the question, just to repeat the second part.
In which cases do you use the treatment antibiotics? Like
okay, I understand. Well,
post surgery antibiotic post surgery.
Yeah, about the antibiotics, I mentioned already. You should have a fast track. You should have a protocol, and make it simple for everybody. So if you have antibiotics and you say, in this patient we need this, in this patient we need that, in this indication we need another regimen, you make it so complex, you will have mistakes. So in my clinic, all patients, virgin cases, redo cases, they all get the same antibiotics. The antibiotics should be given at the time of induction. So before the incision, we use amoxiclavulanic acid, so augmentin, 1 gram intravenously, 24 hours, intravenously 4 doses. We use ciprofloxacin, which is 400 milligrams 3 times. And we use fluconazole, 1 single shot, 400 milligrams. In all patients, 24 hours intravenously, and then they go home and they get per oral medication, which is only augmentin, so amoxiclavulanic acid, and ciprofloxacin perorally for 1 week. All patients, always the same.
Thank you, Professor. Thank you, Professor Renterghem, for sharing your valuable experience for us. I think in Vietnam, the number of people who needs to IPP in the future will be increasingly. So I hope I will have a chance, a second chance to hear you from to hear you your lectures for the next time, and then we will receive a lot of valuable experience from you. Thank you, Professor.
Thank you, Quan, and thank you, everybody. I hope you enjoyed, and I hope to see and meet you all again. Bye-bye. It was a pleasure. Bye-bye.